You're welcome to another edition of Surviving COVID-19, a weekly online series seeking to keep people informed about the coronavirus pandemic so they can better protect themselves. This has become necessary after it became clear that the virus is going to be with us for a while. If this is your first time of joining us, there are 4 other shows you've missed, but which are available on my YouTube channel. Just go to Israel Live. This show will also be uploaded once we're done. It's been some 7 months since the outbreak of SARS-CoV-2, the virus which infects people to give them the novel coronavirus disease, also known as COVID-19. But as the name suggests, it is new, and so very little was known, about it at the start of the outbreak. How it originated itself has remained a global debate among experts and even presidents. There have been various studies about how it is transmitted and how long the virus survives on surfaces. It wasn't until a few months ago that the WHO was compelled to acknowledge that there could be airborne transmission. Again, it wasn't until some months ago that wearing of masks became globally accepted as a way to stop the spread of the disease. So how much more do our scientists know now about COVID-19 that they didn't know 7 months ago, and how much of that information could help us to ensure we are better protected? That's those of us who believe that COVID-19 is real, because of course there are some people who don't quite believe that COVID-19 is real. Now, for this conversation, I brought together some of the finest experts in the field. Now, we have the Dr. Bediako, I'll be introducing him, but we have Dr. Godfred Takyi. He's the acting head of the emergency department and lead clinician at the UGMC COVID-19 treatment center. And then we also have Dr. Peter Kojo Quashie, a virologist and senior research fellow, West Africa Center for Cell Biology of Infectious Pathogens, WACCBIP, University of Ghana. If his institution sounds familiar, yes, it's because we had another expert from WACCBIP last week on this show, and he's with us again this week. He's Dr. Bediako, also a research fellow at the West Africa Center for Cell Biology of Infectious Pathogens. He is an immunologist. Also joining us, as I indicated earlier, is Dr. Godfred Takyi. Now, between a virologist, an immunologist, and a clinician, I believe we should cover all grounds as far as COVID-19 is concerned. Indeed, amongst the 3 of them, any question you have should be adequately answered, and we're going to be dealing with that in a bit. I'm also happy to announce to you that the Star Ghana Foundation, which has been supporting advocacy on COVID-19 among the many other projects it's supporting Ghana, has recognized the Surviving COVID-19 series as a platform that could be used to reach out to Ghanaians, and so has offered us some of its partners who are doing incredible work in the area to share some of their knowledge with us. This morning, we'll be having the Christian Health Association of Ghana, a network of 344 health facilities and health training institutions, join us. It's fair to say CHAG has been at the front line of keeping rural Ghana COVID-19 safe, and its Deputy Executive Director, Dr. James Duah, will be telling us all about it later on. They also have some troubling news about the quality of hand sanitizers on the market, which have found their way into health facilities. You definitely would want to stay tuned in for that. So thank you, Star Ghana Foundation, and thank you, gentlemen, for your time this morning. And I would want to start with you. I believe I'd want to start with Dr. Peter Quashie, if he is set up. My first question to you all is, would you agree that there's so much that you know now about COVID-19 that you didn't know some months ago? And if you do agree, tell us which of all that you have found most revealing. And I'd want to start with you, Dr. Bediako, before we come to Dr. Peter Quashie.
All right. So thank you for the opportunity to once again be on your show. It's I enjoyed myself last week, so it's nice
That's
that
good.
you brought me back, and you brought me back with one of my colleagues. So WACCBIP is making a good showing today.
Yep.
So I mean, I think a number of things have stood out about this pandemic. I mean, it's a novel virus, so nearly everything that has happened has been, you could say, somewhat unexpected or has been surprising. I think what has stood out to me in particular, perhaps, is the large number of asymptomatic cases that really we've seen globally. I mean, a large number of people around the world. It's not just in Ghana or in Africa that we've seen these asymptomatic or mildly symptomatic manifestations of the disease. But the fact that the majority of them are asymptomatic um, it may be not quite surprising, but it presents unique challenges because it makes it difficult to trace this virus. It's unlike Ebola or other outbreaks we are used to that are relatively easily identified, even without molecular testing. This virus is much more, in some ways, insidious in that it spreads from person to person, and these people may not even realize they're infected. And so that is something that has, I think, tested global capacity and has presented certain challenges when it comes to being able to control the virus, because you must test to identify it, to find it, in order to control its spread. And when a large number of people are not apparently sick, it is creating sort of the economic and political and I guess health tensions that we are seeing, in that where do you put your resources? If a lot of people are not getting sick, how do you justify testing at the cost that it costs to test? But of course, for a proportion of people in Ghana, 0.5%, in other countries, well over 1 or maybe even 2%, this virus is killing. And with the sheer numbers, over the tens of millions now infected, we have well over 300,000-400,000 people who have died globally, and in Ghana, I think 206. So that is really probably the thing that stands out to me.
That stands out for
the
you.
top.
All right. We'll be coming to you for a lot more, but let's go to Dr. Peter Quashie now, as briefly as possible, to just set the tone for the much broader conversation. What are some of the things that you found most revealing?
I mean, I think, thank you for having us on the program. I think some of it, Dr. Bediako has already touched upon, which is that the rate at which this virus spread, I think, has been quite unprecedented, at least in the modern era. And the sheer number of cases and the wide diversity of outcomes, and what we are finding is that the different organs that this can have an effect on is quite surprising and in some ways astonishing. When this started, we thought this is similar to SARS CoV-1, which affected China and parts of North America earlier on. So it looked like that was more, we knew something about the virus based on that. Then we found out that, asymptomatic cases can transmit, or there's transmission before you actually start to show symptoms, which is very unusual for most respiratory viruses. So, I mean, there's a lot of things that we could go into here. And then, of course, the initial research was trying to track where the virus came from, and it was suspected that it came from bats because that was the expected next pandemic, basically, was expected to come from a bat reservoir. Now we know that it likely came from bats, but spent some time in intermediate hosts such as the pangolin. I think it's fairly certain now that the pangolin was the intermediate host. So this sort of has culminated in a virus that is almost hybrid in its behavior. And I think that's what's made it quite challenging, both in terms of the diagnosis and in looking at how we can tackle it properly. I'll leave it here for now.
Dr. Peter Quashie, how differently is COVID-19 being transmitted now? Or what are some of the new or popular modes of transmission? Are they emerging modes of transmission peculiar to Ghana or developing countries?
So I think early on, it looked like fomites or virus on surfaces was a big part of the transmission model, especially in Europe and other parts of the world. The latest research I've seen suggests that it's becoming more of aerosols, aerosolized, and also there's increasing evidence that there might be some airborne transmission. Now, how you differentiate airborne from aerosol is basically the size of the drops. But to say that the difference between aerosolized virus and airborne virus is the size of the droplets and how far those droplets can travel. So if you have smaller droplets, they can stay suspended for longer and they can travel further, and potentially they can infect more. So that's where the current research is showing that maybe, contrary to what was indicated initially, we do have quite significant numbers of airborne transmissions. This, I think, is still only at a high risk in healthcare situations where you have high concentration of airborne virus. I do not think, and I don't think the research shows that it's quite concerning in most public environments.
All right, I would want to put the same question to you, Dr. Bediako. How differently is COVID-19 being transmitted now?
Yeah, I think Dr. Quashie has touched on. I mean, I think the big thing was the transition from thinking of fomites and surfaces as perhaps the most deadly to now realizing that it was passing from person to person, either via droplets, like he mentioned, which would be about a meter distance apart, versus these smaller nuclei. Basically, they could be slightly evaporated droplets or aerosols produced by certain activity that could travel further. And I think also the idea that it wasn't just coughing. Obviously, if somebody is coughing, we all get alarmed, but it is very obvious that with talking, singing, any activity where you are basically pushing air out through your lungs and out through your mouth or nose could produce these droplets, which is why guidance has been to minimize social gatherings, church congregations, big events. It was really to prevent or to minimize the risk of spread, because it became very obvious that majority of transmission was not because people touched an infected surface, but really majority of transmission has been from person to person via these nuclei. I mean, I think something that has become quite apparent and is quite interesting is that it appears as though not everybody transmits equally. So there is convincing evidence now that about 80% of cases are actually transmitted by 20% of the infected people. So you have these people who are considered to be super spreaders or super seeders, who a single person infecting 20 people at a particular event. Now, this is thought to partly be biological. So certain people appear to have higher viral loads, but it's also, I think, really related to activity. So if you are in a church and somebody happens to be infected, and they happen to be singing loudly or maybe making announcements around a large group of people, then you could have these sort of superseding events relative to somebody who was quiet or was wearing a mask. So I think that is why you're seeing the advice to wear masks has now increased quite significantly over the last several weeks. Masks have become probably talked about perhaps even more than hand washing, although they are to be used together. But their realization was that by speaking or singing, certain, you had higher risk of transmission, and you had these potential events where you had large gatherings of people with somebody who was, doing certain activity that led them to become super spreaders. And actually, asymptomatic people could have relatively high viral loads. So You could have people who have no signs or symptoms or are mildly symptomatic actually being these super spreaders, not just somebody very, very sick in a hospital who you'd obviously identify as potentially infectious.
So, okay, so that's significant. It doesn't necessarily mean that if you are asymptomatic, then you're not going to be spreading the virus.
No, to the contrary. I mean, the sheer number of infections we have seen could not be simply due to symptomatic people, because as we said, over 80% of infections are asymptomatic. So if you just do the math, if asymptomatic people were not infectious, we would not have a pandemic, because majority of the people who have COVID are asymptomatic. So it demonstrates that in actual fact, majority of the spread has probably been from asymptomatic or pre-symptomatic people. The evidence suggests that about 2 or 3 days before you present with symptoms is when your viral load is highest and you are the most infectious. So there are people who have gone on to have symptoms and others who have not had symptoms. And I think actually a point was made on the show last week. We talk about asymptomatic. There are a lot of people who are not classically asymptomatic. They are just mildly symptomatic. So they had a headache, they had a mild fever. That was the symptom, but they overlooked it. So actually they would not be technically asymptomatic. They would just be mildly symptomatic, they don't feel really sick. But those people are probably the ones largely responsible, I would say, for the spread of this disease, as opposed to the people who've had very severe illness and have been isolated from the beginning.
All right. Now let me go to Dr. Takyi now. As a clinician, I'm hoping that this time your line will be clear so we can hear you. As a clinician, you will be interacting directly with the patients, and I'm sure you've seen all sorts. What can you tell us about the symptoms people present? As I indicated earlier, it used to be coughs and chills, but apparently now there's a whole lot more now. Please break it down for us.
Okay, good morning. Sorry, I had some internet connectivity issues earlier on. Good morning to all my panelists.
Good morning.
And good morning to those watching us and listening to us. It's true what you said. Earlier on, we had a case definition. So we're following the case definition. But as time went on, we're getting people with different presentation. I mean, the interesting one is a patient who came in with severe chest pain that we're hoping we could find something in the chest. Chest CT was done, it was normal. But then there was something about him that wasn't making sense. Initially, when we did further evaluation, we read that he had myocarditis. And later when we tested him for COVID, it was positive. So there are a lot of people who come in with atypical presentation, different or varied from what we knew earlier on. And with any illness, with the passage of time, you gain more insight, you gain more knowledge. And it's not surprising now we've added loss of smell, we've added loss of taste, we've added bodily aches, which is very typical of all viral illnesses. Most people have had flu before, will complain of bodily aches and stuff like that. People are also having diarrhea, sore throat was there, but it wasn't a big deal. But people are now having a lot of GIT symptoms. People come with abdominal pain, diarrhea, vomiting, which were not all there. And the typical presentations of malaria is still there, because most of the presentations or signs and symptoms are as a result of your body trying to mount an immune response. And as your body mounts an immune response, these are some of the constitutional symptoms you tend to have. So anybody with, as our previous panelist said, headaches is part of the complaints, but most people tend to ignore headaches because they think, oh, I'm tired, or I just need para, I'll be fine. But going forward, all the symptoms from headache, fever, the one that we were told initially, headache, fever, chills, sore throat, loss of taste, loss of smell, runny nose was not a feature in the past, but now some people are presenting with runny nose. Basically, some are very atypical. I've seen a patient also complaining of pain in the scrotum, which we had to call the urologist to come and review. We didn't find anything, but we just say, hey, let's just test him for COVID and see. And he came positive. And I actually went online to check. And I was shocked to realize there have been some few cases reported in the US of people with orchitis, that's inflammation of the testis. So we are learning, and as time goes on, we'll learn more. But I'm happy we've expanded the symptom list so we catch people who may not appear to have the classic symptoms that was initially presented to us through WHO. So we can all have a high index of suspicion, so we can pick them early and help them so people don't deteriorate.
All right, so from what you've described, the kind of symptoms you've described, it appears if you feel anything at all, you should probably be suspicious and probably think about the fact that you may have to get a COVID-19 test. Would you say that should be the approach now?
For me, I would rather err on the side of caution.
Yeah.
When I know how my body feels. So if I feel something doesn't make sense, you see, the truth of the matter is that there are so many people out there, about 80%, who are actually asymptomatic. Okay, so let's say you are asymptomatic or you are mildly symptomatic, but you tend to ignore it, only to report to the hospital later with shortness of breath and the rest. We don't want that. Okay, so when you feel you don't feel too well and your symptoms include or may include fever, chills, just like malaria, or you're having some diarrhea, or you're having some body aches or runny nose, I think it would be advisable to get yourself checked by a doctor so we don't have to wait till you get that bad.
What are the options available to people? Because you're saying that you should get yourself checked, but you can't just walk into any facility and say you want to get a COVID-19 test. Indeed, in recent times, COVID-19 tests, unless you're willing to pay for them, you can't easily come by them. We've heard the Ghana Health Service saying they're focusing more on symptomatic patients. So how do you go about it if you feel the way you're suggesting we should go about it?
Okay, Israel, this gives me the opportunity to present a service that was launched at UGMC in conjunction with pharmacists and the Ministry of Health. It's now been replicated in other hospitals like Dept and Ridge Hospital, Greater Accra Regional Hospital. It's called COVID Connect. So it makes use of an app. The app is called Lucy app. I'm sure you've heard of it. Yeah. So for most people in Ghana, you can download the Lucy app. I'm not trying to do publicity stunts for Lucy app, but it's a real useful tool. So with your permission, I want to proceed. So when you download the Lucy app, you fill your symptom profile, and based on your scores, someone will get in touch with you, someone being a doctor from UGMC, University of Ghana Medical Center. So for me, that is one way to look at it. So that's one way. For those who are asymptomatic or may not have any symptoms, but may feel unwell or just want to know their status, as you said, there are places they can go and pay. I also want to say that UGMC, we've started OPD services for people who think they may be having COVID. I don't know of any other facility doing that. Maybe I stand to be corrected. So if you think you're home and you feel there's something not too right with you, you could call our numbers, we arrange, you come in, we see you at our special OPD for COVID-19. If you need to be tested, we test you. If there's really nothing, we reassure you, we have psychiatrists, we have psychologists, then you go back home. Then we follow you up through the Lucy app. But if you come in and there's something that you didn't know, but we picked up, we'll admit you.
All right, so that's fine for those people who are in urban areas, especially Accra. You're talking about the app, you're talking about UGMC. That's for those who are in Accra mainly. But, well, fortunately, we have Dr. James Duah. He is with CHAG, and he will join us later and tell us the options available to people who are not in Accra and in more remote areas in the country. Now, I'm going to put this to, before then though, I want to find out from you, Dr. Bediako and Dr. Quashie, is there anything you want to add to the conversation as to the new symptoms that are coming up?
Well, just to say that the current receptor for the virus has appeared, it appears that it's on so many different organs that actually in some of the communication we have between scientists, people have suggested changing the name to multi-organ virus. And this is part of why it's so critical when you have comorbidities. I mean, this virus is just able to take advantage of any weakness in the system. So just to buttress what Dr. Takyi has said, every time, I think within the last 2 weeks, I have interacted with people with various degrees of runny nose, coughs, and you start asking them how they feel. And the first answer is, no, I don't have COVID, you know? So I think the service that they are providing is, as an outpatient service, is probably something that is needed to be replicated in more hospitals for people to be able to screen. Because yes, the tests are actually hard to come by and quite expensive. So there should be a mechanism of pre-screening people rather than just go for a test. So yeah, that's the only thing I would add to that.
But talking about it being a multi-organ disease, I think it's one of the things that we've come to know in the last few months. So I want Dr. Takyi to touch on that. The nature of the disease and the fact that you may get COVID and recover. This point has been made several times, that you may get COVID and recover, but it does not necessarily mean that you're out of the woods. Or you may be asymptomatic and you may have COVID, but that does not also mean that you're fine. So I want you to elaborate on that, Dr. Takyi.
Sorry, Israel, I didn't quite catch it. Could you just repeat?
So it has to do with, Dr. Peter Quashie was just making the point that, and it has been made several times on this platform, that COVID-19 has become a multi-organ disease, as in it affects various parts of the body. So with that knowledge, which is one of the things we've come to learn in recent times, I just want you to tell us what your experience has been like from the clinician's point of view.
Okay, just to expand on what I said earlier on, you could see that I mentioned somebody getting inflammation of the testes. We've also had people who had come in chest pain that as I said, we've realized was more of a myocarditis from the virus, which was never captured or mentioned previously. Okay, we've had people come with what we call COVID-19 psychosis. As in, these are people who don't have any pre-existing psychiatric illness. But then they have COVID, and down the line, whilst being cared for, start having delusions, having hallucinations. Then you get the neurologist or psychiatrist review, then they tell you it's part of COVID-19 psychosis. So, as I said, there have been people with GIT symptoms. So that means it affects the GI tract all the way from the mouth to your anal region, okay? It affects your liver because people come with deranged liver enzymes. It can affect your kidney function. It can affect your heart. It can affect your central nervous system. So the current science is showing, as my colleague just said, that it's about receptors, okay? Because this is not like a medical platform. I don't use too much technicalities or technical jargons, sure. But it's about receptors. And the virus take advantage of the receptors on a lot of organs. So when they use the receptors as a point of entry to get access, and the current science evolving tell us that we are having a lot of receptors in a lot of organs. That's how come we are now moving towards a multi-organ disease, as has been stated on this platform, as you said.
So with it being a multi-organ disease, the question I'm asking is, there are people who are asymptomatic. They probably would never show symptoms. And there are people who may also never test for COVID-19 because they are asymptomatic. The virus will probably just go through them and they'll recover. What advice do you have for people like that generally, who are asymptomatic. They probably may never test for COVID-19 until they feel they're fine. Are these people likely to be exposed to some form of organ damage in the future?
Okay, I can't sit on this platform and say categorically that they will get a form of permanent injury to any of their organs. But what I have to sound a word of caution here. All of us on the panel, including me, including you, and all those listening or watching us, we are not out of the woods with respect to COVID-19. So we must all, my simple advice, all of us must adhere to the safety and preventive protocols. All of us, i.e. hand washing, social distancing, face masks. And let me say that face masks alone will not save anyone. You need to have the face mask on and adhere to the rest. And you see people wearing face masks and they've gone for social gathering and they think they are fine because they are wearing face masks. If you don't maintain the social distance, okay, your hand could touch something. And in trying to adjust your face mask, you can infect yourself. So being asymptomatic or being pre-symptomatic or whatever category of classification we put you in, we must all adhere to the safety and preventive protocols that have been outlined several times on media and talk shows, and we should all adhere to it. Otherwise, we'll be in trouble. Because today you are negative, tomorrow you could be positive. And you may not, as I said, you've not even tested. You don't know. And you could be the super spreader or super shedder. You could just be infecting innocent people, your old man at home, somebody with a chronic disease like hypertension, diabetes, kidney disease, asthma, somebody with cancer who's on chemo. I mean, the list is exhaustive. It's not exhaustive, but what I'm trying to say is that being asymptomatic, still you have a lot of responsibility to yourself and to the people around you to be responsible. So you don't know what you have. I never go home straight from work. I take everything off, just left with my singlet, boxers, and I even drop off my shoe and my socks, wash my hands before I enter my room. My kids never understand this. They still don't understand why they can't come and hug me from work. I'm trying to be responsible. So we all owe it as a duty to ourselves and the community around us to be very responsible, asymptomatic or not. We have to still continue adhering to the safety protocols.
Now, what's the science regarding transmission in temperate climate versus the tropics? And is it really the case that Africa has largely been spared because of our weather?
I've had this question many times. I don't know whether
I want Dr. Bediako to take that.
Okay, I'm sure every panelist either wants or doesn't want to handle this question. So I'll do my best and I'll see if I'll add anything. Listen, I mean, I think that at the beginning there was some talk, even in Ghana, by certain high-ranking officials that potentially our weather could protect us. You know, in science, you deal with data and you deal with evidence. Now, let's look in Africa, for instance. Where have we seen, in fact, before even COVID, where did we see MERS, right? Where have we seen coronavirus outbreaks before? We saw them in the Middle East, we saw them in Egypt. Those are, as far as I know, they are very hot places. I've not been to Egypt before, but what I can tell from everything I've seen on TV, it's not necessarily a temperate location. Now, even if we think about the coronavirus, I think some of the highest mortality, and especially at the beginning of the outbreak, some of the highest case fatality rates and even viral transmission rates were in North Africa. So we saw, I think, Algeria, Tunisia has done really well to bring their things down, but now they seem to be rebounding cases again. So North Africa, places that are sometimes even hotter than in Ghana, had high spread. Now, in Ghana alone, you can see now we had 40,000. It hasn't been an exceptionally cold time in Ghana. It has been, as you know, seasonably hot as it usually is. And then you can look at the US and in Europe. They are going through summer. The US has not really shown a decline. If anything, Texas, others, California have shown higher rates of COVID during these times. So I read a report once that the link between, seasonal outbreaks has less, sometimes there can be a component of cold weather affecting transmission, but it's also human habits. In temperate areas, when it's winter, people are indoors. They are breathing in recycled air, and it's basically recycled air, heating, all of that creates an environment that promotes the spread of respiratory viruses. So it's not so much that it is cold, and so the virus is happy in the cold. It's just that because it's cold, people are indoors and are around each other, and so it spreads. Now in Ghana, we are in a hot country, but where do we spend most of our time? Indoors in air condition, which is basically like the flip side of being in a cold place and being indoors in a heated house. So it's really about transmission from person to person. What are the activities? So I think that is why very early on there were lockdowns, there were bans on social gatherings. Some of these bans still are maintained. As Dr. Takyi said, it's not just wearing a mask, it is social distancing. If somebody has the virus, but I'm more than 2 meters away from them and I'm wearing a mask, my risk of catching from them drops to very, very low. If on the other hand, I'm standing very close to them or I'm sitting next to them in a trotro, as we discussed last week on this show, and they are talking or they are not wearing a mask, potentially I am much more at risk. So I think, all the evidence suggests that if Africa has indeed, fared better than other regions, which based on our mortality rates appears to be the case for now. And once again, as Dr. Takyi said, we are not out of the woods. The moment we relax is when the thing explodes in our face. But for now, at least in Ghana, our case fatality rate of 0.5 is lower than in other places. We can be thankful for that. I suspect it is less to do about the weather and more about perhaps our population structure. We have a younger population. The median age in Africa is 19 years old versus about 38, over almost 40 in other parts of the world. That means our population structure means we have fewer old people. In Ghana, life expectancy is 63. In other countries, it's over 80. So the most vulnerable people, the people who have carried the burden of death, have largely been elderly and then people with comorbidities. The challenge we have, though, is we have a high number of people with undiagnosed comorbidities. I'm sure Dr. Takyi will probably talk more about that. So just because you are young doesn't mean you are safe. We always sound that caution. On the one side, we say Africa has probably done well so far, partly because we are younger. Also, we are a little bit more isolated from the rest of the world. I mean, in terms of travel, there are more, even though it is much different than it was maybe 10 years ago. If you compare the US, how they are linked with China and Europe, you cannot compare that to the number of flights that come in Accra or come onto the continent of Africa. Africa is still slightly more isolated than the rest. And so the virus took a bit longer to get here. But I think, just to go back to your original question, I think it's all the evidence would suggest that just the fact that it's sunny outside or it's hot has very little to do with blunting this virus. Because once again, think about where the virus spends most of its time. It's not on a seat or on a bench, it's inside your body. And all our body temperatures are kept, no matter where you are, as long as you're alive, your body temperature is the same. So the virus is happy in your lungs, just waiting for you to cough. And once you cough in an air-conditioned room, in an office, in a bank, in a trotro, in a school classroom, wherever it is, the transmission will happen. It's not so much that the virus is floating around in the middle of sunny Accra trying to find somebody.
Dr. Quashie, I want to put the same question to you. You're the virologist, are we better off because we find ourselves in Africa?
Well, I'll start off by yes, only because of location and connectiveness to the world. I mean, that was initially. And I don't think there's a single virologist who thought that the virus would never appear in Ghana or in Africa. Because early on, there's an app which you can look at the flights that go on around the world. And you see that for just maybe every 10 flights to a European city, there's one to an African city. And so the reason why we had a delayed outbreak is just because of the regularity of flights that were coming in from infected places. Now, I agree with pretty much all of what Dr. Bediako said. There's only some emerging evidence which shows that maybe having high humidity can somehow impair transmissibility, but that is not something that has been very conclusive, and I don't think it's these are in controlled environments. So I don't think it's a huge factor in transmission. I agree that mostly it's because, actually, if you look at our death rate in Ghana, if you then factor in the age profiles of the people who have been infected, and you take into account that at a certain age brackets, if you look at the early data from China, certain ages, you have a high rate of mortality. I think when you normalize it, you will probably find that our death rate in Ghana is not that unusual. It's because of the age profile of the people who have been infected and the comorbidity profile of the people who have been infected. There are people who are now dying with no comorbidities, but Dr. Bediako has touched on the fact that there are a lot of people in this country with undiagnosed disease. And so when you actually go into it and do a full investigation, you will probably find that they had previously undiagnosed diabetes, hypertension, and the like. Now, just to say one thing, I mean, this question, like he said, is something that we all think about every day. And as much as I strongly believe it's linked to our age structure, it could also be linked to where a lot of the vulnerable people spend their time, which is outdoors. And research has shown that transmissions outdoors are far lower than indoors. Most transmissions actually occur indoors. In Europe, and it's an emerging topic among scientists, which is not talked about much in the general populace, that there may have been a lot of transmissions through central ventilation systems, because a lot of infections happened while people were at home isolated. And in those apartment buildings where you have central ventilation, the efficacy of the filters that are in there are not that good. So there's a lot of factors which point to our uniqueness in Africa, to being connected but not so connected, that are linking our lower levels of disease and also our lower levels of mortality.
All right.
That being said, there are some countries which have high levels of mortality within Africa. And I think that may also be linked to the sort of management that is being carried out in different countries. That's where the differences will probably come from.
Right. Now, there have been those who say that Africa probably has been spared, not so spared, but we're not realizing or seeing the number of cases as seen elsewhere because we're probably not doing enough tests. So we're not testing, and the people are not showing up at medical facilities to get tested because really don't have that many medical facilities. And they may be having the COVID, they may be asymptomatic, and so they're surviving. What do you make of this testing thing? I'll come to you, Dr. Bediako.
I mean, I think the testing thing is a valid point. Like I said in my intro, you know, this disease is different from many other pandemics or epidemics that you've seen, in that it's very hidden. It only, you know, a small fraction of people who are infected will present with symptoms serious enough to take them to the hospital. Majority of people will just take paracetamol or not feel anything at all. And so testing has been the bedrock. The WHO and actually the Ghana Health Service have also, you know, and the president, His Excellency the President in his speeches have constantly talked about testing, tracing, isolating. The idea that the only way to really control the spread of this disease is by widespread testing. And so Africa has had a challenge in that, you know, this virus is also difficult to test for. It's not cheap to test for. It's a virus, it's a respiratory virus, and typically respiratory viruses need to be detected by PCR. So I think now, you know, before this pandemic, probably maybe 2% of Ghanaians knew what PCR was. Now probably every Ghanaian has at least read PCR. They may not understand PCR the way some of us do, but you know, PCR has suddenly become famous. And the reason is that to detect COVID infection, currently the only reliable method, or at least the gold standard, the best we have, it has its limitations, but the best we have is PCR. And so that means that our traditional rapid diagnostic test methods, which are mostly antibody-based. So when you go for a malaria test, it's an antigen actually test. Or sometimes you go for hepatitis B and you get the surface antigen. You are looking for antibodies that your body has made in response to exposure. And antibodies are much easier to detect and often much cheaper to detect because we have relatively straightforward technology to allow us to, basically like on a dipstick, like a pregnancy test almost, you can detect these antibodies. And so a number of people have made these tests. Even in Ghana, KNUST released an antibody test that typically would only cost $1 or $2 to test. The problem is, because of the nature of COVID, antibodies alone do not indicate current infection. Antibodies indicate exposure. So many of us, like, as an immunologist, it's something I've gone hoarse trying to argue with people, that just because you have COVID antibodies doesn't mean you are currently infected. It just means that you have come into contact with the virus in the past. So while it is useful on a national scale for us to understand the prevalence, for us to understand, okay, what kind of percentage of people in Ghana have actually been exposed to COVID, antibodies will be very useful for that. But if Dr. Takyi wants to know whether or not the patient sitting in front of him is currently infected with COVID, an antibody test doesn't help him. Now, COVID is further complicated by the fact that the antibodies don't last long. So you could be infected today and be antibody positive. And in 3 weeks, I test you again and you are negative. Dr. Quashie is actually currently involved in a study where at WACCBIP, we're actually doing this right now. And we've demonstrated that people who we knew were PCR positive and then had antibodies, we've tested them over time. And after about 3 or 4 weeks, antibodies are gone. So that also means that even antibodies are a poor marker of exposure in certain cases. So that is the challenge we have in Africa. Now, a PCR test costs anywhere, currently the number the government has quoted is about $100. Even if you try to bring it down, it won't be below $50 a test. Now, if you think about 30 million Ghanaians times $50, that is a challenge for a country of our size and our economic standing. Even in America, they're challenged with testing everybody. So I think Africa has a problem of testing. I'm proud to say that Ghana is doing well compared to some African countries. Some countries have decided we won't test, and so we'll not report any case. So COVID is not a problem. And that's, the equivalent of sticking your head in the sand and hoping that everything goes away. Ghana has not taken that approach. I think we can be proud of that. The challenge we have in Ghana now, though, is maintaining our progress. Because like Dr. Takyi says, we've tested, we've done about over 300,000 tests. Unfortunately, as of today, those tests are practically worthless because those people who were negative might be positive now. So we almost have to go back and test all those 300,000 people again. And so you can see how economically that becomes a big challenge. So I believe we need to start thinking in terms of targeted testing. Like Dr. Quashie said, how can we screen different people based on their risk profile and then test? We cannot stop testing. I'm a little bit troubled. Lately, I've noticed that the testing numbers are dropping. We tested only 2,000 people the last time they released results. In the past, we're averaging around 5,000. I don't know if that's a blip or if it's a shift in policy based on economics. But we cannot afford to slow down testing, because if we slow down our testing, yes, our number of active cases will decline because we are detecting fewer people. But then there's a possibility and maybe even a likelihood that more people will now be spreading without realizing it. And then people like Dr. Takyi will start finding more and more people who are seriously sick, needing care, which begins to put a strain on our health system, which has lots of effects, which is what we've been trying to prevent from the very beginning. So I think the testing issue is one where it's economically challenging, but you have to keep, unfortunately, you have to keep pushing. So Ghana has done well. We've done 370,000. If we stop testing today, it's possible that all that 370,000 tests and all the money and all the progress will be for nothing, because the virus will just go up again and we have no way of controlling it. So that is the thing about testing. It's unforgiving in that you just have to keep going and find, hopefully there'll be cheaper tests on the market soon. Hopefully we can innovate in that space. But we have to keep testing.
Now, Dr. Takyi, your name has come up a few times in the last few minutes. Are you, from what you said, you're a clinician, do you get the impression, because we look at the active cases that the Ghana Health Service has been publishing in recent times, and there's the indication that we're having fewer people getting COVID-19. Is that what you get from where you sit as a clinician? Are you seeing less patients than before?
It's consistent with the reporting system from Ghana Health Service. I'm an emergency physician, and so we have a place where we receive suspected cases and we test them, then later we move them to the COVID treatment center. I also double as the one in charge of the COVID treatment center. And I can tell you, through the emergency, at the moment, we have only one patient. In the past, people are actually banging on our doors to bring in suspected cases. So it's gone down. At the COVID treatment center, we don't have more than 15 patients. In the past, we've had over 28 patients on a daily basis, despite discharges. So it looks like we are not getting a lot of cases coming to us, which, as I said, is consistent with what Ghana Health Service is reporting. So the danger here, you may think, oh, we are getting less cases, but it could be that we are actually not picking new cases because they are not coming for testing. Even with our OPD system for COVID, the attendance have dropped. With our Lusky app, patients accessing the service, it's dropped. So I can't tell whether it is a true reflection that people are adhering to the safety protocols and so we are not getting exposed, we are not getting cases, or is it that people are not really coming in to assess the service? I can't tell. At this stage, it's difficult to say. By the next few weeks, we'll see whether it's the reality or it's something that is not coming to our attention. We'll see.
Let me take that question to Dr. Peter Quashie. What do you make of what is happening? It's interesting. If we're not getting as many cases at the UGMC and the rest, that suggests that indeed, as the Ghana Health Service has been indicating, our active cases are going down. So we're having less people being infected.
So as for less people being infected, I think even the numbers will show you that that's not true. The real issue here is, I think it's threefold. If you look at the positivity rate has gone up. And in the past, we were able to test a lot at a high rate because we were pulling samples and having reagents and the like. Now, once your positivity rate goes above 8 to 10%, you can't pull samples anymore. You have to run one by one by one. So whereas the same reaction in the past, you could have done 10 samples, now you're doing one. So from the same reagents that you would have used to do 100,000 tests, you're now doing 10,000 tests. And I think that's why our rate of testing has dropped drastically. Now, what that translates to is if you're testing less people, you have more backlog. These people never get a result. And I think it's gotten to the point where if your sample is 3 weeks old, it potentially may be discarded. You will never get a result. And in Dr. Bediako,
I like you to clarify that. You're saying that what? If your sample is 3 weeks old,
that is hearsay. But
no, it's actually, let me jump in. It's actually the official policy. I've seen it in an official policy document that they are prioritizing samples that are at least within 2 weeks because the discharge period is 14 days. So if Dr. Takyi sends a sample and it comes back after 14 days, it's no use to him. So the official policy to deal with the backlog has actually been that they prioritize. But I think that now my understanding is the backlog has been cleared, so things are moving better. But
so
beyond 14 days, they wouldn't test it.
So one thing we've noticed, Dr. Bediako mentioned that we are screening mostly healthcare workers, but we're moving to the public pretty soon. But one thing we've noticed that there have been people who have taken a test, never got their results, and they have antibodies. and we've gotten a number of them. They never got a result back, which means that during their period of time waiting, and they weren't necessarily in government isolation, if they were not taking precautions themselves to self-isolate, these people were walking around thinking they were fine. And in most cases, these were asymptomatic people. We've seen that in health professionals, we've seen that in the public. So that's, I don't think that the fact that there's less burden at the centers is indicative of less spread. What it actually may mean, and that it might be a boon to us, is that we are not seeing people falling down dead as is happening in other countries. There are countries where they are refusing to address it, or even they are addressing it, but the spread is so much that people are literally dying on the streets, and they are going around and picking them up. So this is the one thing that really is the silver lining that you can see in this. And that's one of the things that we are really trying to understand, if there's something beyond our age structure that is protecting us.
So with this information, I mean, you're saying that we're not having people falling dead in the streets. We're not having people, you know, thronging the hospitals, being sick. And and yet you're also saying that it doesn't mean that we're done with COVID yet. Should we just, you know, forget about everything, throw caution to the wind, and go about our lives as normal? Because really, COVID is not killing as many people. And indeed, that's the position some people are adopting. You look around and you see people who are not wearing nose masks because they think that, hey, COVID is not that scary after all. And there's people who say, I've had COVID, and yeah, it was so mild. It was really nothing. Why should I worry about COVID? Should we really be worried about COVID? And I'm putting this question to all of you. I'd want to start with Dr. Takyi.
Okay, thank you, Israel. For me, it's a very dangerous path to take, to think that because you've had COVID before and it was mild, so no problem. What about the next person to you that you could easily infect, who may not be as lucky as you and may have a severe disease? And don't forget, Ghanaians in general don't do a lot of what we call routine medical check. So there are so many people walking about with chronic illnesses they have no ideas of. And then you get infected with COVID. In fact, let me tell you, about more than half of our patients, we've actually diagnosed them with chronic illnesses when they come in. They had no idea they had those chronic illnesses. And we wanted to be sure it wasn't the COVID that was pushing them to have such parameters. And when they were about recovering, those parameters were still there. So for me, it's a very dangerous path to chart, that to say that because COVID is mild, let's continue with our life as normal. I have a problem with that thinking, okay? And secondly, yes, we're not dying as other people. We may not know the actual reason. It could be beyond the fact that the demographics could be in our favor. We don't know other hidden, a lot of people have subscribed to, the intervention of the divine, which as Christians or as faith-based people, we tend to believe that. But going beyond that, I think we should be very, very careful the way we handle this COVID, because we don't have the health infrastructure like other countries in the West. And they are having a lot of challenges. You see, UGMC is here, Ghana East is there. They just had the Ghana Infectious Disease Center, 100 bed. How much is our population? We are way beyond the existing facilities. So it's very dangerous for us to assume that because the disease is mild or we've not lost so many people, to relax and go back to life as normal. Israel, to be honest with you, if you take outside Accra and probably Kumasi, which regions in Ghana can actually boast of significant infrastructure to take care of COVID if they need severe cases? Look, I sit here and I get calls around the day, midnight and stuff. people being referred from Western region, people being referred from Kumasi, even Kumasi referred cases here. Just to let you know how serious the issue is. You see, it's not my place to come to the media and cause fear and panic. But the reality is that, yes, our cases may, in quotes, appear to be going down as in active cases, but there could be other reasons, as has been discussed on this platform, that may be why we are getting smaller cases. But for me, where I sit now, I will not recommend to anyone, irrespective of their agenda, their political status, that we are out of the woods, so everybody should relax. I will not recommend that. I even have issues with some of the restrictions, like easing of restrictions, like the trotro.
I love it.
I have a serious challenge with we just saying we should wear face masks and so we should be in trotro and no social distancing. I have a serious exception to that advice. I don't know who informed that policy.
What is it that you know that the people who advised government to take that decision don't know?
We are in church. You say because people are singing in church, so they should have social distance. Who tells you is right? In trotro, people don't talk in trotro. People sit in trotro and sell drugs and see all sorts of things. People even preach in trotros and other buses. And we've all sat in trotro and buses before God bless us and we have our own cars. The activities that goes on in cars, especially public transport, it's not different from what goes on in the church. So how then do we skew our restrictions? I don't get it. I don't know. I know some people may be angry with me for saying this, but it just doesn't make scientific sense to me. Seriously, it doesn't. It doesn't at all. And that is how I feel about this trotro thing. Seriously, Israel, I'm not happy about it.
Dr. Bediako, you're one of those who's also not excited about this trotro agenda. But yeah, we're looking at the cases. See, Dr. Takyi has said something. I want you to convince people who are out there who are deciding that COVID is mild. COVID is, you get some mild symptoms, you recover, you're likely to die. How do you convince people like that? Because if you also look at the active cases coming down, Dr. Takyi is talking about the fact that we're not having as many people coming into UGMC. We're not overwhelmed, essentially. It means we should be forgetting about COVID-19.
I mean, I think I agree entirely, 100% with everything Dr. Takyi has said. I mean, I think, listen, as scientists, as clinicians, as public health officials, you always want to be proven wrong, right? None of us want to see Ghanaians dying on the street. So you are always in that, you are like a prophet who is predicting something and you are praying that it never happens. But when it doesn't happen, then they say, you see, you were talking too much, you were an alarmist. I would rather be labeled as an alarmist at the end of all of this than not saying what I think everybody around the world, or at least the science, is saying. So yes, we are speaking, we are promoting, or we are advocating for caution. We are not saying for sure that Ghana is going to be hit and overwhelmed, but we are saying that there is the risk. And the risk is based on looking around the world. Listen, everywhere around the world, there are people just like us. Fundamentally, 99.9% of our DNA is the same. If you say even Black people, the people who are dying in America are Black people. In fact, disproportionately higher numbers of deaths are in minority populations, largely African-American populations. Now, that probably has more to do with socioeconomic, healthcare access issues in America than with race. But as Dr. Takyi says, many people in this country have equivalent or worse access to care than poor African-Americans in America. So, for whatever reason, I'm a Christian, I believe that, God looks after us. Yes, we can say that for now, we thank God that so far, the death rates in Ghana appear to be lower than other places. But it doesn't mean that we should now relax. If our case rates are really dropping, as Dr. Takyi is saying, they are seeing fewer people at the emergency, we are thankful for that. But let's not forget what we have been doing to try to get there. As much as we might criticize and say, I have been saying we need to do more, why are we easing restrictions? Ghana was one of the first countries to implement a lockdown. Ghana was one of the first countries to close her borders. All those things are the reason why our case rates are where they are. We have had a consistent policy of testing. Noguchi has, I worked for 6 weeks, 12-hour shifts at Noguchi testing samples. I sleepwalked into a wall one time. I decided I had to retire because I might be found on the street somewhere. But
sorry about
people
that.
have been working. Oh no, it's okay. I'm sure there are people who work harder than me. But my point is, people have been working really hard to control this virus as best we can. And we've had some success. But that doesn't mean that we should just say, okay, we stop. The moment we stop, there's a risk that this virus will rebound. America saw declines. They began to open up. Now look what's happening. 1,000 Americans are dying every day. This is a country that has 100, maybe 1,000 times the resources we do, and was showing declines. They were managing to control it. They relaxed, and now it has exploded, and they don't know what to do. Europe has had similar situations. Sweden was going for herd immunity. Go and ask them what's happening. Australia is nicely isolated. It's an island unto itself. Melbourne is now on lockdown, right? They've locked down parts of Australia for the past several weeks, and the thing is not going. So the moment you underestimate this virus, it shows you another side. And so I think right now, Ghana is at a point where if indeed our cases are dropping, this is when we need to even put more restrictions, because now we have a chance to kill this thing now. They say when you're killing a snake, you cut off the head. Now the snake may be wounded. It may be weak. This is not the time to relax and go back to long 2-hour church services and trotro rides and all of that. This is the time to double down on the restrictions and get rid of this pandemic in Ghana for good. The moment we relax, it will come up. Because as Dr. Quashie is saying, just because the people who are very, very sick are dropping, does not mean the virus is still not spreading. For even if we are testing fewer people, the proportion of tests that are coming back positive is rising. Our positivity rate is over 10. In fact, at one point it was over 20%. Okay, I think the last time I checked, we had 400 new cases. They did about 2,000 tests. That's almost 25% positivity rate.
Yes.
Right? So our positivity rate is high. It means the virus is around. It is just not making us very sick. So now we have a chance to maybe get a grip on it. In Kenya, trotros they've removed the backs of every other seat. So you can't even sit there. They've decided not to open school till next year. You know, these are African countries. Ghana was ahead of Kenya by far in our response. But now I begin to wonder, why are we easing restrictions when other countries who have similar case fatality rates as us are doubling down on the measures? So I think, you know, just to add to what Dr. Takyi is saying, people should not get complacent. Even if we stay at 0.5%, we are 30 million people. 0.5% of 30 million is 150,000. Are we willing to accept 150,000 deaths in Ghana? Right? Right now we have 206. That is 206 families who have been bereaved, right? One death, if it's, you know, I lost my dad 10 years ago. One death can hit you just as hard as, you know, when it's somebody else, you think, oh, it's only 200. America, 1,000 are dying every day. That's 200 families who have lost somebody. What happens when we hit 1,000, 10,000? And that is where we are going. If things stay as they are, 0.5%, we'll just keep rising in terms of deaths gradually. So, and as Dr. Takyi is saying, the last thing, it's all about a cliff. Ghana, we've done well, but we have limited resources and we have limited healthcare capacity, and it's concentrated in the urban areas. Urban areas took the brunt of COVID because that is where it came in. The airport is right in Accra, then Kumasi, then Cape Coast. These are our big cities. So maybe we are saturating the big cities, but let's also not forget where our elderly people are and where the vulnerable people are. They are in the rural areas where there's no access to care.
Yes.
So now let's say the virus may be dipping, but I suspect it could be the end of the first wave and the beginning of a second wave. And the second wave could be in the hinterland, where we have very little hope of trying to control it. Now they are talking about flu breaking out in the eastern region. So even COVID is not done, and we have an outbreak of flu in schools, right? So let's just, you know, I think it's not about inspiring fear. I believe we need to keep doing what we've been doing. We mustn't relax. We must find the resources and the willpower to crush COVID now when it appears to be receding. I say appears to be receding because, to be honest, if you look everywhere else, it comes in waves. So this may be the end, it may be a dip, and in 2 weeks, we may be on the same platform saying things are, you know, UGMC is getting overwhelmed. So we have to just keep that in mind. The virus is out there, and let's stay committed. I would vote to bring back some restrictions. I fully support Dr. Takyi. We have to revise some of those guidelines because it is too risky. And let them later on say we were overcautious. I'd rather be overcautious than risk more lives.
But the thing is, if we're imposing the restrictions, it has economic implications. And I believe that's one of the things that the government is also looking at. One of the people who has also been doing some great work as far as COVID-19 advocacy is concerned is Kwame Sapong-Esiedu. He was on the show last week. He sent me a message which I want to share with you. It says the active case drop is mainly due to the fact that over 54% of all daily cases reported in the last 28 days have been out of the 14-day time window. The data is there to prove it. I'll bring you in here, Dr. Peter Quashie, at this point. How do you respond to this from Kwame Sapong-Esiedu?
I agree with them perfectly. I cannot sit anywhere and say that I believe that cases are dropping. I do not believe it for a second. It doesn't matter what the case count shows. That is not biology. There's nothing that I think that our initial reaction, as Dr. Bediako has mentioned, was very strong, very powerful, and very effective. Unfortunately, while the science was supporting it, we started to, and I can understand the stance in terms of the economy. We started to release restrictions. However, there are some release of restrictions, such as the trotros, which I do not believe can be strongly supported by an economic argument, because the fares were raised to counteract that. You see, if there's a need, if anything, as Dr. Bediako suggested, if we even believe that this is going away, that our case count is dropping, then that's when you step on the neck and you crush it. Because you cannot play, unfortunately, as much as we want to, you cannot play politics with biology, and especially not viruses. Anywhere in the world, any type of virus is one of the most pernicious sort of infections you can have. It's even before COVID. Usually if you have a cold, which is a viral infection, they'll tell you to take some rest because there's not much can be done for you in that scenario. So what we are seeing here is, even if, let's just say, we are seeing a decline in cases, that is all the more reason why we should increase and maintain our restrictions. There's different ways to do it. You don't have to have a full, I don't think going back to lockdown scenario will work at all. And it's, I mean, our experiment.
All right, we appear to have a challenge with the connection to Dr. Peter Quashie there. I'll quickly move on, bring in this question, and I put this question to you, Dr. Bediako. There have been talk about immunity from the disease, that if you have COVID, if you've recovered from COVID, you have immunity. What do we know about immunity from COVID-19, Dr. Bediako?
Immunity to COVID, I mean, the story is still evolving. We are still learning a lot. As I mentioned earlier, there is clear evidence that early on you elicit antibody responses. So that is a branch of our immune system. The very, very beginning, as soon as the virus enters, it activates your innate immune system. And in fact, a lot of the negative symptoms, the fever, the chills, the inflammation, that is typically your innate immune system responding. And as Dr. Takyi said, it is your body trying to fight off the disease that actually gives you these symptoms that make you so uncomfortable. But then after about 3 to 4 days, your adaptive immune system takes over, and that leads to the production of antibodies. and then T cells. People may have heard of T cells in the context of HIV, for instance. So we focus a lot on antibodies because, like I said, they are easy to measure and they're actually very effective. In fact, every vaccine currently licensed globally that we use to treat individuals, not really to treat, to vaccinate children especially, is based mostly, the mechanism of action is largely antibody mediated. So antibodies are very, very effective, or can be very, very effective at preventing disease, and in many ways also treating a disease. So within COVID, there has been talk of using plasma, blood from people who have recovered that contains antibodies. And I believe actually UGMC is beginning a study on using what they call convalescent plasma. So in other countries, and now thankfully also thanks to the efforts at UGMC, you can store blood from people who've recovered and use it to treat people who are seriously ill, because the antibodies in that blood are effective against the virus. So that is promising. The problem with immunity is how long does it last? And that is where COVID appears to be presenting a challenge. Certainly, antibody-mediated immunity appears to wane over time, relatively quickly. Something like measles, you have lifelong protection. The antibodies are just there. With coronaviruses like common cold, they don't last because we keep getting colds. COVID appears to sort of fit in that category. So antibodies appear to wane. However, there is evidence that T-cell immunity is established. And there is quite a bit, there is now optimism that T-cell immunity may actually, be longer lasting and may be persistent. Now, the thing about antibodies is just because your level of antibody drops doesn't mean your body cannot produce them when needed. So that is something to keep in mind. If we test you and your antibody level is low, it doesn't mean you are not immune. It just means that your circulating level is low, but upon challenge, upon exposure, you could then suddenly make more antibodies, especially if you have a good T-cell response. So I'm not, immunology is a subject I teach here. I'm not trying to teach a whole lecture on this platform. I'll try to stay away from that. But I read a really interesting article this week, a brilliant article trying to explain the immune system and immunity of COVID. And it basically started with the line, the immune system is very complicated. And that, fortunately or unfortunately, is where we find ourselves. It is really complicated to the point that an immune response doesn't mean you are immune. So the challenge we have currently with all the vaccines that are being tested, many of them have been proven to elicit an immune response, which is fantastic. You don't induce immunity without the immune response. The problem is immune responses are not necessarily protective. Right. So that is where we are. We know that COVID induces a robust immune response. We know that elements of this could be useful in treatment and hopefully useful in prevention. It's just that we don't know how long this immunity lasts. So we don't yet know if once you are exposed and you recover from COVID, whether that means for the rest of your life you are protected. Right. We don't know that. COVID has not been around long enough. But we are hoping to take advantage of elements of that in the development of a vaccine. And we hope that one of the, over 100, at least 6 of them are currently in phase 3 trials. We hope that one of them might demonstrate enough protection to be licensed and released. But that is where we are.
Let me bring in Dr. Takyi here. You're a clinician. From where you sit, do you get, we've heard elsewhere around the world that people have had COVID more than once. Do you get that from where you sit?
It's right. So far, I haven't seen anyone that would discharge that has come back with being positive for COVID. What actually I have seen is some people test positive almost forever. Some people have tested positive about 8 times, some 7 times. But we still manage to send them home, okay? We still manage to send them home. So that's the other thing I want to report, because I'm sure maybe a lot of people are not aware. I'm sure my colleagues, virologists, immunologists are aware, because they do the testing, so I'm sure they are aware. Some people test positive forever. Yeah, we don't know why, but maybe they may shed light on it, I don't know.
Oh, that's interesting. But from where you said, you don't have a case where people have tested, they've been discharged, they've recovered, and then they've had to come back?
Not when they come back with something different. And they don't test positive. All those we've discharged from UGMC, we've seen over 200 patients. All those we've discharged so far, none has come back with a complaint that has tested positive. They may come back with something, maybe they come back, they're not feeling well, we test and realize it's malaria, or they have something different, or maybe they have a UTI, urinary tract infection, but not testing positive again. I haven't seen such a case yet in UGMC. I can't speak for the other centers in Ghana, but what I can speak to is the fact that some people test positive forever. They are in a minority. We don't know why.
That's interesting. Do you have any answers as far as that is concerned? I'll put that to you, Dr. Quashie. Why is it that somebody will test COVID-19 positive forever?
Yeah, so it's in the nature of the test. The test does not test for the entire virus. It tests for parts of the virus. So it's, and depending on the test, most tests, I think, test for 2 parts of the DNA, of the RNA of the virus. So if you have, what has been shown elsewhere is that what Dr. Takyi is talking about happens quite a bit. And there's been some studies where they've seen that some of the people who are testing positive are no longer infected, but what they have is fragments of viral RNA which are still in their system. So when you test it, it's going to be positive, but they cannot isolate a full virus from them, which means that they are not actually not infected. It's just that maybe they had such a high viral load. That means they had so many viruses in them that once they were cleared, there's still residual remnants there. Actually, I'm aware of, there was somebody who was testing 8 times positive, but they were fine. It's,
I just want to add one more thing.
All right.
Earlier on, we started taking care of COVID patients and COVID-19 patients in UGMC. There were a few observations that we made, which was very interesting. That was the time we were using 2 negatives as the criteria for discharge. So some people come in positive, then we test them after 14 days, they are negative. So we are hopeful and expectant that the next one will be negative and send them home. Then they test positive. We saw that trend. And I realized, I asked my colleagues in Ghana East, to be specific, Dr. Oliver Comey, and he said, yeah, he's also seen some cases like that. But they eventually test double negative and we discharge them. So those are all some of the dynamics that come into play. And it's not easy for the patient because they were hoping to go home. And nobody wants to be confined to a place where you can't walk around, you're always in a room, you only come out a few times. It's like you are in a mini prison. So it's not easy. That's why the care of COVID-19 is very comprehensive. If you are caring for COVID-19 patients and you take away the psychological aspect, where you don't get involved either clinical psychologists or psychiatrists, especially clinical psychologists, then you are a bit deficient in your care. Because let's not forget the definition of health. The definition of health is not the absence of disease. It's a whole thing, you know. So sound mind and all that is very important. So this is what I want to say about this. I don't know if Dr. Bediako and Quashie want to add something to it.
For Dr. Quashie, I'd want to ask you what you make of this people getting, forever testing positive.
Yeah, I mean, I think we are fortunate with this disease that it's something for the first time, one of the first times it was reported on outside Ghana and Africa, and there's quite a strong case record for these cases. So in people who test negative and then positive, some of the early reports coming out of South Korea especially show that sometimes because the virus infects in the nasal and oral passages and then gradually goes to the lungs, there's a case where you might test negative because we're not doing the lavage, which is usually where you get 100, you know for sure that this negative test is a negative test. You might not pick it, but then it's in the lungs. And then later on, if if it replicates more, which it becomes more, you might detect it again. And then you have a negative test, which becomes a positive test. Double negative is, I think, the one sure way to know for sure that you've cleared the virus. So that's, but of course, as this progressed, it became, the economic argument has become quite strong. And you put that into the backdrop of low symptomatic cases, our country's economic status, and then it really becomes very difficult to justify waiting on a double negative. And so I've had this question posed to me many times about how do I feel about the change to 14-day discharge? And I say that the statistics support it, that it makes sense. But there will always be those outliers.
All right, I would want to bring in the CHAG at this point. I'm sure they also have some stuff to share with us. So much of the COVID-19 advocacy, as we know it, has focused on the urban population. Thankfully, though, the Christian Health Association of Ghana, a network of 344 health facilities and health training institutions, is doing some incredible work in the rural areas. CHAG is a network of 344. They're mainly 34 different Christian church denominations that have come together, and they provide healthcare to the most vulnerable and underprivileged population groups in all 16 regions of Ghana, particularly in the remote areas. Its Deputy Executive Director, Dr. James Duah, has joined us. I introduced him at the beginning of the program. He has joined us and is going to be part of the conversation from here on. Thanks to Star Ghana Foundation for making him available to us. And thank you once again for making time to join us. What is the main challenge with tackling COVID-19 in your operational areas, which are not so urbanized, Dr. Duah?
Right, thank you very much, Israel. And let me say good afternoon to all your viewers. And also say Ayiko to all our 30,000 workers who are working in remote areas across the country, specifically in 188 districts. Yes, as you said, one of the difficulties in working in remote areas, just like any other health facility located in a remote area, has to do with resources for responding to COVID. We are all aware of the shortage of PPEs across the country, not only in Ghana, but in other parts of the world. Again, it has to do with the design of our health facilities, pre-compliant. In other words, you need an entry point to the facility and a place where you go out. But the design of health facilities are not like that. So when emergency strikes like this, then you have to think about redesigning and all that. Thirdly, it has to do with getting critical staff to those areas who will respond to COVID. And fourth, has to do with how do you protect the workers so that they respond to this COVID, amidst the fact that you have a large number of people who access the services in these facilities. If these facilities are not there, people will have to travel long distances to the cities to access health services. And now in this period, we are talking about, restricting the number of travels because you have to use public transport. And in many cases, in rural areas, sometimes transportation is a difficulty. So how do you equip the staff, build their capacity in a way that they can take care of all the catchment population so that they limit transportation to the cities to respond to COVID?
You've asked a number of...
These are some of the challenges that we encounter. And not only Come again, Israel.
We're having some challenges with your line. I hope the connection is a lot better. But you've asked you've told us about the challenges that you're encountering. And the question I'm going to put back to you is, how are you addressing these challenges? How are you managing the situation?
Right. So this is where I want to express our profound appreciation to Star Ghana Foundation for coming in to support us to respond to COVID. Star Ghana has supported us to design education for the rural communities where we are operating from. You are aware that in many communities, they don't have access to TV, they don't have access to radio. And one thing that has come out from this COVID is the fact that people fear the hospital environment because of the various information that is being shared. And so when people are not coming to the hospital where they can receive accurate information and they don't have access to TV or radio, how do you reach out to them to talk about COVID and also create demand for services in order that you don't leave one day to manage complications because these people are not coming to the hospital? So Star Ghana support allowed us to produce essential information on COVID, and importantly, not to wait for them to come to the facility, but also to take it to their homes. There are several advantages of this response in the sense that whilst the people are not coming to hospital, especially for essential service like maternal and child health, pregnant women are pregnant, they are staying at home, they don't have anywhere to go. And because of fear, they are not coming to the hospital. So this support gave us the opportunity to take the essential information that we have developed to households. And we did 50,000 households. And so the information centered on prevention and control of COVID. It addressed fears related to COVID that is spread so much in the rural areas. It addressed the issue of stigma and discrimination. Israel, I'm sure you are aware of the situation where people return to their homes, especially the Kaya people, and some had to reject them because of so many information about where they are coming from and all that. So when we reach out to those homes, it allows us to share the information on them, address the issue of stigma and discrimination, and also provide services that are needed for people who were not rather visiting the hospital. So we address the issue of ANC, non-communicable diseases for people with hypertension, diabetes that are staying at home, and also other questions that people who listen to TV or radio will not have opportunity to address. Importantly, it also gave us the opportunity to train our staff, and we have done 560 staff training on infection prevention and control related to COVID, and also case management for our staff who are in rural areas where they are not having access to this information.
So, you see, one of the questions that came up earlier, or we heard Dr. Takyi earlier talk about the fact that if you have, he feels that as much as possible, people should test. And if you have any slight, you feel have any funny feeling in your body, you should probably go test. And he talks about the app that's available that you can use. What happens to people who are in rural communities where they don't have access to these apps and they don't have access to UGMC and they can't just walk into any health facility? How do they, what should they do when they feel that they have symptoms?
Okay, so part of our house-to-house engagement encouraged all such people with such symptoms or feeling to come to the hospital. And what we did was that we connected them to testing centers. And also in many cases, our facilities took samples and sent them to KCCR, to Noguchi and other places that are testing. So we facilitated the testing for these cases. Importantly, one of the education that we gave to our staff was also triaging in all the facilities. So if you walk to any CHAC facility now, right from the security point, everybody is involved in triaging who is coming in terms of taking travel history. And here I'm not emphasizing on travel outside the country, but even within Ghana, travel history and other essential information that is required. These helped us in putting cases to where they need to go and also facilitating testing at the appropriate places. And now the question that you are asking is also leading us to our next action that we want to take as an organization.
Yes, please go on. Tell us about this next action you intend to take.
All right. So beyond the Star Ghana support for us, I mean, in terms of sending information and reaching out to people's homes, one of the gaps that we have identified, and it's not unique to CHAG, is the fact that how do you get people in remote areas to test and get the results in good time so that you can plan in terms of prevention, further spread among staff, among other community members. And so we are going to expand testing to these communities. We will be supported by DFID to optimize the use of gene expert machines. You are aware that the Global Fund has gene expert machines for testing TB. And these gene expert machines can be used to test for COVID. The 10 pair it with using PCR testing. And so we will be able to test these in about 40 locations that are outside the big cities. We are going to collaborate with Noguchi, Ghana Health Service, and FDA to do this, so that if I live in Boko and in the northern region where most CHAG facilities are, and in BA, and a client comes and I cannot get the test within, 24 hours, or now the average is about 2 weeks or 3 weeks. When staff are exposed without having the test results, you don't know what to do with them. And by the time it comes, they may also be, have contact with several other people. So it leads to spreading more and more. So we will be able to get the test results within 24 hours. That will help planning in protecting the staff, in protecting the community, in fashioning out education to all the other areas. And again, we are also going to train more people to do case management so that case management centers will increase. At the moment, 10 CHAG facilities are designated as treatment centers, including Brekum, Techiman, Akwatia, Bato, and many other places. We want to increase these case management centers so that right across the country, access to case management, access to testing, access to information will increase in all these areas.
All right. Let me bring the conversation to the rest of the panelists that we have this morning or this afternoon. Now, we've heard what CHAG is doing around the country with donor support, and they're talking about some wonderful ideas. They're talking about gene testing, that one of the methods that's available to them. Why is it, I want to ask, let's be frank here, is this something that's really doable, or they would attempt to want to do something for the rural population? And if that's really doable amongst the rural population, is this something we should be looking at replicating for the urban areas where we're talking about tests delaying for 3 weeks and on? I want to start with you, Dr. Peter Quashie.
I think there are a number of gene expert machines in the country, and I think it's something that can be doable. South Africa, I think, mostly is using gene expert machines for their testing. It's, I think no one would disagree that one of the next phase of our COVID response should be just massively increasing testing centers, because, and I mean, I think organizations like CHAG are doing a very commendable job, because sometimes we forget that there's places outside Accra. I mean, in this case, we've said, oh, most of the cases are in Accra, so that's justified. But if we really want to root it out, we have to be targeting also the rural areas, the places with less access to healthcare. So I think that is something that can be brought on board in terms of the reagents, they'll probably also have similar challenges to reagents as is being experienced with the standard PCR test. But if it can be, and that reagent hurdle can be surpassed, I think that is something that's commendable and that is very much needed. So, yeah.
Dr. Bediako, what do you make of what CHAG is trying to do in the rural with its gene expert? I want to ask, cost-wise, how does that compare with the PCR test, for instance?
So I'm not up to date on the exact cost of the reagent. The gene expert machines, I mean, it is a PCR-based test. So let's just be clear. Gene expert is PCR. It's just what we call a point of care device. So devices that have been developed, and gene experts are mostly used in TB, up until now, have really been used in TB diagnosis, which is why South Africa, given their high burden of HIV and TB comorbidity, have a lot of gene experts on hand. These are devices that are relatively easier to use. You don't need as much technical experience to run a test using a gene expert machine. So the idea of using gene experts in more remote areas is a very good one, because that is what gene experts are designed for. They are designed to take some of these complicated tests to the community level. So you don't have to have a centralized lab the way you need a Noguchi or KCCR. So I think the idea to use gene experts is a really good one. The government actually mentioned gene experts in one of the first addresses of the president. He talked about the purchase of gene experts. I think there were certain logistical challenges in rolling them out as they had hoped. I'm happy to see that I think now these machines have now been made available, and I think certain numbers of tests have been made available. I think what CHAG is doing is extremely commendable. I think actually we need more of such initiatives to really, as Dr. Quashie is saying, ramp up the capacity. I think it should not just be the purview of government to do testing. I think private enterprise, private organizations can be involved. I think up until now, I personally have found that the private, with the exception of the Ghana Infectious Disease Center, majority of the private support has come in the way of donations of PPE or donations of money to existing healthcare facilities. While that has been very helpful, I think we are reaching a point where we need to diversify this support so that some of it can now go towards targeting, initiatives such as rural testing. And I think using gene expert devices will be one thing. It is one platform. Certainly, we have to, a strategic approach would look at the cost of running gene experts versus the cost of collecting samples and transporting them to a centralized location. Because often when you do things in large numbers, like you can at KCCR or Noguchi, the cost per test drops because you are able to do many, the platforms are designed to be what we call high throughput, which means the individual cost is lower. Point of care devices are fast and are convenient to use in rural locations, but they are not very scalable. So if you are doing just 100 tests, it works to do it on a gene expert. If now you've collected 1,000 samples from a whole surrounding rural area, it may not make sense to run it on a gene expert. It may be cheaper to transport it to your nearest regional health facility. So I think what I would recommend is a combined approach of gene expert point of care machines in maybe the most remote areas, and then regional labs, which I think the government has established, like Tamale, I think Western region has one. Obviously in Accra, we have them. Maybe in Koforidua, all the regional capitals should have a centralized testing lab, which would support the rural initiative so that very, very far away with 10, 20, 30 people, you run it on a gene expert. If you aggregate 1,000 samples, then you take it to your regional lab. I think that would work out to be more economically viable.
All right.
But I think it should be a combination of public and private partnerships.
Okay. I have Dr. Peter Quashie having his hand up. Dr. Peter Quashie.
I just wanted to, in this discussion, we've been talking about prioritizing testing, but I think we haven't mentioned the reason why that's important. The important is you have to know who is infected so that you can now isolate those people or advise them to isolate. So that's where we've seemed to have gone away from this advice on isolating. So if we are testing the positives and they are not being isolated, then the reason for doing the test becomes moot. So I think it's something that we have to look at. If we're not, yeah.
Okay, that's fine. I want to go back to Dr. James Duah. We have heard Dr. Takyi talk about the fact that at UGMC, they're not getting as many cases as they used to. I want to find out from you, is it the same situation in the operational areas where CHAG is? Because we're also hearing from the Ghana Health Service that there are some regions really that are not reporting any case. What's the situation like in your neck of the woods?
Well, thank you. I think in the rural areas, we are not witnessing many cases because, this is my thinking, that we are not testing enough. And here's the reason. You know, in many of our facilities, if you take a sample to send to, let's say, Accra or Kumasi, some facilities have reported that they have to bear the cost of transportation. And indeed, in one facility, it costs as high as, say, 200 Ghana cedis. Now, if you take a sample for 10 suspected cases and you have to send, that will be about 2,000. How do you continue to send these samples amidst the challenges in resources? And again, because it takes quite a long time to do the testing, you don't have adequate numbers that are being tested. So the few cases at the district and the rural areas, I guess, has to do with the limited numbers that we are testing. If we begin to test more, I think that the picture will change from what we are seeing now. And of course, let me also say that I think quite a lot of education has gone in. People are now very conscious about hand hygiene, including the widespread use of alcohol-based hand sanitizers, hand washing, social distancing. That is basically the result of the efforts that the whole country has put in terms of educating the masses on prevention measures and its generalized adoption by all.
One of the things that you've done as CHAG, I got to realize, is that you've also been doing tests on the hand sanitizers available on the market. And you've come up with some very interesting findings. Tell us about this, because it turns out that some of the hand sanitizers on the market are actually substandard.
Whilst many people adopt use of alcohol-based sanitizers, they should also be mindful that hand washing is one single most important aspect of prevention.
I'm happy to hear that at least Ghana, FDA is looking into that, and we'll be waiting for the outcome of their findings. But I want to ask Dr. Takyi. Dr. Takyi, have you actually had those concerns come up as a clinician?
So are you asking now about the hand sanitizers?
Yeah, the hand sanitizer issue.
Oh, okay. For me, I've said on many media platforms that I've been on since we started the fight against COVID-19. I've always said that the best form of hand hygiene is hand washing with soap water. And I always give an narrative that when we are going to the operating room, or most people call them theaters, we don't use sanitizers, we use soap and water. So when you are somewhere or your circumstance allow you to test with water, then you can use the alcohol-based hand sanitizer. So for me, I don't preach more of the sanitizers. I've said it on KSM show, I've said it on Pambo show, on TV3, I've said it to Graphic Online, I've said it on many other platforms, that the key is just what Dr. Duah is washing with soap for hand hygiene. Too much of sanitizers. But then I've also stressed that people actually check not just the label, also talk to some few people with some knowledge in sanitizers to be sure that the brand they are getting is actually credible. Because it's very dangerous to be using a sanitizer that you think this percentage of alcohol. Let me give a scenario. Some time ago, there was a brand of ceftriaxone when I was in Tamale that we were using for patients, and the patients never recover. So those who can afford, we can sell, which is from a different company. And immediately within 24 hours, you see the fever going down. So then we made issue about the drug and reported to FDA at the looked into it, and that drug was taken off the market. So we are all supposed to be vigilant and observe. It's not just giving care to patients, but we must be mindful of some of the things that's happening. So we take it from there. Otherwise, you end up prescribing things to patients that may not be useful. You haven't bothered to check. Hand washing is key. Then in addition, always find recommended brands. So I don't know if FDA can help us with brands they recommend as the person will just read and believe and move on. And I'm sure Israel, if we all pick a hand sanitizer and we read the label 70%, we may believe it because we don't have anything at that moment to check the percentage. So here I'm appealing to the FDA, if they can come out with a list of recommended hand sanitizer that they've checked, that actually has, I think that would go a long way to help all of us. Thank you.
All right, great. But the challenge too is that there are times that they may have the hand sanitizers and they may have approved them. I'm sure Dr. Duah, you realize that they may have approved them, but what they approve for the people, they send a sample to FDA and it is approved. But what ends up on the market may not be exactly what was approved. Dr. Duah.
Right. This is where, I mean, this is what brings me to this point that in this fight, it is an all-inclusive affair. All of us have to be responsive and check. And this is why we want to thank Star Ghana for giving us that capacity to be able to do. You know, Israel, you meant right, that FDA can approve right product content, but then when it gets to the market, who knows what somebody will do? People produce with the same labels and send to the market. So it is up to us, the end users, to make sure that what we are receiving is the right thing to use. And of course, it's a protection of communities that safeguard. And then what up, and I'm very thankful to FDA for the swift manner in which they have responded to this matter. So it's an all-inclusive affair. And again, I mean, you mentioned, right, that government cannot also do this alone. All of us have to come into the picture. There are roles that all of us can play and make sure that the appropriate authorities and agencies are informed of their services. And if there are some things that are not right, we tell them accordingly. This is what I think will help us in containing this pandemic.
All right. I know we're just about running out of time. We've actually run out of time, but I want to chip this in.
Israel, can I just say something?
Sure. Yeah, Dr.
Israel,
Tutu.
what I was trying to say was that, you see, for the ordinary Ghanaian, if I'm going to buy something and I pick and it's labeled FDA approved 70%, how am I going to tell the time I'm purchasing that product that it is actually 60, 70? How can I tell? I can't tell. So what I'm saying is that I know the work of FDA is not just a one-time approval. I know they do continuous surveillance and all that. That is what I'm appealing to the FDA to do to help us here. Because yes, I'm a clinician, I've gone to school, I have a lot of titles. I can't even tell whether this product actually contains what it says it contains. How can I tell when I'm buying it? I can't. Yeah. That's the point I'm making, Israel. Thank you.
Okay. But beyond that, like you're also advising, the best way out is to just wash your hands with soap under running water, which you feel is the best way out of the problem. But so the final point I just want to take quickly from all of you, how far have we gone when it comes to vaccine development? There's been a lot of progress made with vaccine development. Indeed, Russia has announced that vaccines are almost ready. When can Ghanaians expect to have doses administered to them? I'll start with you, Dr. Takyi.
I would throw this ball to the virologist and the immunologist to respond.
Okay.
Then I'll come and say something later.
Okay. All right. So, Dr. Peter Quashie.
I think it would depend on which vaccine becomes approved first. There's quite a swell for amongst countries for there to be a vaccine for all, which is at a vaccine that's distributed at cost. So if that vaccine is produced first, that's a possibility. Beyond that, I mean, I can't hazard. Vaccine development is a very long and very up and down process. So I would not be comfortable hazarding a guess as to when. Hopefully it's within the year. Worst case scenario, hopefully next year. But I cannot, looking at even what's on the what's in development now, there's no way to tell definitely or even tentatively which one would make it and when we would have access to it. As we're seeing with some of the reagents, I'll just say, even though there's this kumbaya spirit going on with COVID, what most people don't know is that there are certain reagents that we cannot get from Europe. You cannot buy masks from the UK, for instance, because they are restricted for their own personal use. So I suspect this is what's going to happen for a lot of these vaccines.
Dr. Bediako, can we be hopeful?
Yeah, I mean, we must always remain hopeful. If you don't have hope, without hope, then, I mean, we might as well just go and sit and cry in a corner. So we have hope. And there's a lot to be hopeful for. Like we've been saying, we are doing okay. We are surviving so far. And I believe we will continue to survive, and we will be fine, provided we do what needs to be done. In terms of a vaccine, as an immunologist, I'll tell you, the world has not yet developed a vaccine in less than a year, ever. Nearly every vaccine we have took 10 years to develop, at a minimum. Malaria, I've been doing malaria work for the past, 8 years. Malaria, they've been trying to get us a malaria vaccine for over probably 40 years. We still don't have a malaria vaccine. Having said that, the world has probably also never seen the mobilization of resources such as this, because it is a global problem. People don't care about malaria anywhere as much as they care about COVID, because COVID can affect them in developed countries. So there's a reason why the US initiative is called Warp Speed. We are trying to do something that's unprecedented. We are fortunate to have 6 currently in phase 3 trials, which is, like I said on your show the other time, phase 3 trial is the only time that now the efficacy becomes a factor. Up until this point, it's just about money, because producing a vaccine costs money, testing its safety costs money, testing an immune response, like we said, is just a matter of money. Most vaccines will give you some immune response. It doesn't mean anything about whether the vaccine works. So it's only now that we are going to get real data as to whether or not any of these vaccines actually protect people. Then the next question is, how well do they protect? Is it 30%? Is it 50%? Is it 80%? Most vaccines have to be above 90%. I suspect for this one, we will lower the threshold because it's such an emergency. And even if it's 50%, we'll say, well, it's protecting 1 out of 2, we'll go with it. The problem is, then it's no longer a silver bullet, right? So we might have a vaccine, but if it's not a highly effective vaccine, it will protect some people, but won't protect everybody, and so will not solve the problem. And the final thing is availability. Obviously, as a poorer country, as a low middle income country, we are at the bottom of the pack when it comes to ordinarily access. Now, there are initiatives like Gavi that are saying they will buy and make available to poorer countries. Having said that, they cannot buy what is not there. And America and UK have already ordered, I think, 90 million. I think the UK has already placed an order for 90 million doses. Vaccines take time to make. So what I suspect will happen is the big countries will order all the stock, and then once they've got theirs, then Gavi will then have access to buy. There may be campaigns to prevent that from happening, more equitable distribution, but as we've seen with face masks, as we've seen with PCR reagents, when push comes to shove, all ethics go out of the window and it's just about survival, and the survival of the richest. So I think this is why we've been saying, let's prevent the spread, because even when there's a vaccine, we don't know when we will get it. Right now, there are things we can do that are not dependent on anybody else. Minimizing contact, wearing face masks, washing our hands. We don't need America to do this for us. We don't need the UK to do this, but we can do this ourselves. So let's minimize the spread so our runway is longer, so that when the vaccine becomes available, we get it, and then we join the world in celebrating. But for now, I think we have to focus on what is within our control, and that is really in not rushing to reopen, not rushing to relax restrictions, but really knuckling down and crushing this locally,
right,
and being an example to the rest of the
Dr. James, your take on vaccines?
Right. Once the immunologists have spoken, let me make it short. But I think it's something that is doable, and we are hopeful. As a public health physician, hope is that they come soon. But as Dr. Bediako said, we are not hoping that within the next couple of years it will happen, but maybe 2 years or more. But that will be quite a lot of news and good thing for us, because as you all know, vaccine and vaccination is the single most important public health prevention measure that the whole world has witnessed. And we look forward to when we can have vaccine for this pandemic. Let me end by adding that, Dr. Takyi, so whilst we are all busy as physicians, I think that I'm going back to the issue of hand sanitizer. Let's optimize the pharmacists that we have in our system. They really, really, really do a good job. Some of them produce the hand sanitizer with the right content. They can help us with the testing in order to protect the public. Thank you very much.
James, just to respond to that with the permission of Israel, UGMC, actually, we have our own customized hand sanitizer. We have. Our pharmacists have done that already. All right. I didn't want to talk about it today.
Could I just, one more thing before we go, about the vaccines. I think my scientist colleagues will be mad at me if I don't say this. One thing that we need to learn from this situation is that we are truly on our own. And maybe today we don't have the capacity to make a vaccine, but we have the brain power in this country to make vaccines. That is not a problem. We have the human capacity. We have just not invested sufficiently in our research capacity in this country to be able to do it at this stage. What Ghana must take from this, Ghana will be here after COVID. I pray that all of us will make it and we will all survive. But what we need to learn from this, which we didn't learn when Ebola dodged us, is that we must invest in our local scientific capacity. It's not enough to have Noguchi and KCCR be the two leading centers when they are mostly funded by Japanese or German money. This country needs to be self-sufficient from a biomedical research standpoint, which means we need to think about how to fund the work that scientists do in this country. Currently, Dr. Quashie and I and all the scientists in this country are primarily funded from overseas. We have very little support from our own government for the work that we do, and that means that it is not sustainable. So we need to raise money and we need to fund research. I think there's a bill in Parliament. Since I'm here, I'll say it. There's a bill in Parliament called the National Research Fund. It has been there for 2 years. I think this government or the next government needs to make that a priority, fund it at a high level. So the next time Ghanaian scientists are called upon to respond to a problem, we actually are ready and are equipped to solve our own problems and maybe help solve problems elsewhere. They'll come and ask us for the vaccine next time.
Sure.
Thank you. That's all I want to say.
Doctor, I can make some comments about my facility.
You deferred comment on the vaccine, so it's your take now.
No, about my facility. Before I go off the program and people get angry at me, I want to, if it's your permission, I want to say thanks to the team on the ground, because it's not just about me. The hardworking nurses, doctors, pharmacists, the orderlies, those who clean the place, the cleaners. I want to say thank you to all of them, okay? They are doing a lot of good job, which probably will never be mentioned, okay? And I also want to say that we've had good leadership here. Our CEO is a very humble person, unassuming, great leader. Our medical director, our CEO is Dr. Darius Osei. Our medical director is Dr. Inim Buama. We have excellent additional directors who assist them. And I want to say that UGMC is not just a COVID hospital. We are still open to the public. We take care of all manner of illnesses, and we are still taking care of patients. So people who want to come to UGMC for their illness, where patient-centered care is optimum, please don't hesitate and come around. Thank you for the opportunity to say this.
All right, and thank you. I think at this point, it's fair to also give the same shout out to all the healthcare workers around the country, the orderlies, the nurses, the doctors, the specialists, everybody, wherever you are, and those involved in the COVID-19 fight, including the scientists, of course, Dr. Quashie and Dr. Bediako, all of you who have been at the forefront of all of this. We want to say a big thank you to you. So thank you to you all for also being part of this program. Dr. Peter Quashie, virologist and senior research fellow at the West Africa Center for Cell Biology of Infectious Pathogens, University of Ghana. Then Dr. Bediako is also a research fellow at the West Africa Center for Cell Biology of Infectious Pathogens. He's an immunologist. Dr. Godfred Takyi is the acting head of the emergency department and lead clinician at the UGMC COVID-19 Treatment Center. And of course, Dr. James Duah, who is the Deputy Executive Director of the Christian Health Association of Ghana. Thank you very much for making time to join us. Let's make time, same time next week. You have a wonderful rest this Sunday. Bye-bye.
Thank you.